البيوبسي ولا الفايندنجز الموجوده؟
انا بقول بناين وبعدين بعد كده بقارن بالفايندنجز اللي يعني بقول بناين according to the findings. بعد كده بيبقى في حاجات ثانيه بتساعدني عشان اكونفيرم الكلام اللي انا بقوله. يعني مثلا حالات السيست انا بكونفيرم بالالترا ساوند. انا دلوقتي بقيم الكونتراست انهانس ماموجرافي، فلازم يبقى عندي another techniques to confirm عشان اقيم هذا this technique. In cases of benign lesions such as مثلا cyst او fibroadenoma, I can depend on the ultrasound.
حضرتك you will advise for fine needle aspiration or biopsy or I will take it as a surgeon to do it.
بص حضرتك احنا we do an ultrasound and mammography. Okay? If I reach the diagnosis by these two techniques, it's enough. But if I'm still يعني doubt, I will do a biopsy. Okay? To confirm الكلام بتاعي. In مثلا our institute مفيش patient انا قلت ان هي malignant lesion بس لازم I have to confirm my
هستأذن حضرتك احنا وصلنا في مرحله دلوقتي ان اعتمد على الراديولوجي كراجل جراح ان انا اشيل على مسؤوليته ولا اخد اذا كنت انا فاين نيدل اسبيريشن سيتولوجي ما بعتمدش عليها.
مفيش عيان هتخش من غير ما يكون معاك باثولوجيكال تحت. ماشي اوكي فلازم يبقى معاك باثولوجيكال تحت. لكن لو حاجه بناين وانا قلت وانا I confirm ان هي بناين بالالتراساوند بالماموجرافي بالكونتاكت ماموجرافي بالام ار بكل الكلام ده خلاص انا محمد حضرتك هتدخل مجرد تشيل الحاجه اللي انت عايزها.
لسه في بعض الحالات نزلت من الفاين نيدل اسبيريشن سيتولوجيست لان ما عنديش سيتولوجيست ريسبكت هيم سيلف انه يقول لي دي كذا او كذا لازم
يا دكتور حضرتك عندك فروزن سكشن، عندك فروزن سكشن وانت بتشتغل. فروزن سكشن كمان؟
بتقارن بالفاين نيدل ولا
بقول لحضرتك الام ار يعني اديني بناين او اديني مالجنت.
برضه حضرتك فيها فرق.
طبعا يعني
هو بس في الاخر احنا يعني الفيروس كلاسيفيكيشن فقط عشان كده هو ده حتى لو هيساعدني انا كراديولوجيست في الاخر انا بطلع لحضرتك الريبورتس في كاتيجوري فيروس فانا اكوردنج للي انا شايفاه هقول لحضرتك فور
لا
ايوه لو
اه
انا كده قلت
حضرتك فور يبقى في حاجات
كده
ايوه
في حاجات لازم حضرتك مش هتدخل عمليه الا لما تكون يعني احنا عارفين.
يعني انا لو كتبت
حتى لو انا قلت لك مالجنت
انا لو كتبت
حتى لو انا قلت لك مالجنت
and now
مفيش
thank you.
تدخل عمليه حتى لو انا ديفنت ان هي مالجنت انا كونفيرمد ان هي مالجنت لكن لازم يبقى عمل.
Thank you, Dr. Maha. And now we move on to the next presentation. Does 3D tomosynthesis increase the diagnostic accuracy of digital mammography? Presented by Dr. Noran Hussein.
Thank you, Dr. Magda. First of all, before we go into details of 3D mammography, we should ask ourselves why are we considering 3D mammography? And the answer is that 15 to 30% of screening detected cancers are not seen by mammography. The principle of tomosynthesis is that it takes thin sections, and we can say that an X-ray of the chest is comparable to a mammogram, while a CT of the chest is comparable to a tomosynthesis. If we go through the principle of tomosynthesis, we first take one pre-shot image, followed by a series of images which are actually taken 25 degrees on either side. The detector is in place while the tube moves, and there are a series of 25 projections that are taken, and they are recorded into our machine and reconstructed to give us the 3D image. The slice thickness that we see is usually 1 millimeter slice thickness, and if we have a breast that is compressed into 4 centimeters, it means that we will have 40 images. It's important to note that these images must be viewed on a 5 megapixel workstation. One of the earliest studies done on 3D mammography was done by Anderson and Ikeda, and their results showed that cancer visibility was higher in 55% of cases by tomosynthesis, and it showed it well that they decreased recall rates by 40%, had a higher positive predictive value, a higher cancer detection rate, and increased mammographic accuracy. The purpose of our study was to assess the value of adding 3D breast tomosynthesis to full-field digital mammography for improving lesion visibility and BI-RADS in relation to pathology. We performed the study on 929 cases in which about 71% were screening while 30% were diagnostic. And we performed the study in both craniocaudal and mediolateral oblique views, in both mammography and tomosynthesis. And we did our BI-RADS scoring for mammography alone, then we did it again after adding tomosynthesis, then we gave a final score according to any additional findings by ultrasound or additional views. We correlated all of this to pathology. Our results showed that about 5.5% were categorized as BI-RADS 4, which is probably malignant, and 4.7% were categorized as BI-RADS 5, which is malignant by radiology. Out of the 300 cases that were given BI-RADS 1, 18 cases were upgraded to BI-RADS 3, 4 cases to BI-RADS 4, and no cases to BI-RADS 5. Out of the 424 cases given BI-RADS 2 by mammography alone, 4 cases were upgraded to BI-RADS 3, 3 cases to BI-RADS 4, and 1 case to BI-RADS 5 when we looked at the tomosynthesis images. According to the 124 BI-RADS 3 cases, 10 were upgraded to BI-RADS 4 and 3 to BI-RADS 5, and 15 cases were upgraded to BI-RADS 5 out of the 45 cases given BI-RADS 4 by mammography. There was no change in the BI-RADS 5 diagnosis. Our results showed an agreement between mammography alone and final BI-RADS of 81%, while there was an agreement increased to 91.8% when we added tomosynthesis. 3D Tomo also added new information in 20% of our cases by visualization of margins, analysis of focal asymmetry, and detecting multifocality and multicentricity of cancers. According to breast density, in the almost fatty breast, there was no change in the percent of cancers detected. When we had scattered tissue, there was an increase of 2% when we added tomosynthesis. However, there were vast results in heterogeneously dense breast, in which cancer detection increased from 45% to 72%, and in the extremely dense breast, it increased from 5.8% to 76.4%. There was a significant p-value. In evaluation of microcalcifications, we didn't find any significance in the evaluation. Only 1 case was upgraded to BI-RADS 3 and 1 case was upgraded from 4 to 5. And our results showed that the accuracy increased to 98% and the negative predictive value increased to 99%. We're going to look at a few cases, and this first case is a screening mammogram of a 59-year-old woman, and for us we looked at this in mammography and we didn't see anything definite. When we did our tomosynthesis, we found a spiculated mass seen on the left breast lower outer quadrant, and we can see retrospectively this area on mammography, and we can see that it looks like a subtle density. Retrospectively, you can see some irregularities at its border, but we did not notice it on the mammography alone. The next case is a patient who came with a right breast lump, and we can see the lump here very clearly. And we didn't see anything else in the rest of the breast. It was a dense nodular breast on either side. And actually, tomosynthesis showed us another cancer seen here. And look retrospectively, you can see that it's just dense nodular tissue, very difficult to see it alone. And we actually found 2 more cancers as well. So this patient actually had a multicentric cancer. It was 4 cancers, not only 1, as we saw by mammography alone. This next case was also a screening case in which we found a focal asymmetry on mammography, and we can see it clearly here in the upper outer quadrant. But tomosynthesis showed its spiculated margins, and this was an invasive duct carcinoma. Compare it to 2D mammography. This is another case of a focal asymmetry as well, very similar to the first one. However, there was nothing on tomosynthesis in the same area, and this was actually proved to be just focal glandular tissue, and this was proved by follow-up over 2 years and a negative MRI. This next case is very interesting because the patient had a mastectomy, and this was her she had a right mastectomy, and this was her left breast, and she was on screening. She has a few intramammary lymph nodes, a few increased densities in certain areas, but you can't really tell where, if there is an abnormality or not. And in the tomo image, we found the cancer here. Look retrospectively at the mammogram. You can barely see anything on the mammogram. It's just a subtle density, and here we have a spiculated carcinoma, which was a 6 millimeter invasive duct carcinoma in a woman who had a right mastectomy. This next case is also a patient on screening. And tomosynthesis found an area of architectural distortion over here, which there was nothing on the mammogram. However, we biopsied it, and actually it was just PASH, pseudoangiomatous stromal hyperplasia. And this case is a patient who had a right conservative surgery, so the breast is a bit distorted, and you can't really compare it to the other side because of the scarring. And we found actually in this area a spiculated mass in the retroareolar region, and it had spiculations reaching towards the skin here. Also, this was a recurrent invasive duct carcinoma. So the take-home messages for 3D mammography. The pros are that it improves mass characterization and margin analysis, it enhances evaluation of focal asymmetry, it improves accuracy of BI-RADS categorization, and increases cancer detection rate in dense breasts. However, you always have to beware of dose and try to use tomo and mammo in one exposure. It increases the imaging time, but not as much as you would imagine, and it needs experience definitely. It did not show significant performance in microcalcifications detection and analysis. Thank you very much for your attention.
Thank you so much, Dr. Nouran. Any questions for Dr. Nouran?